Okay, so Assalamu alaikum, welcome everyone on board. So today we will be discussing some points about neuroanesthesia, and because everything is written in the books, so the purpose for me to conduct these sessions is just to give you an overview and just to highlight the things which are important. Okay, so Shahriyar, if I just ask you, what do you think that what are the things which are important for you to learn for from neuroanesthesia, or what, like, how would you like to approach? Yes, Shahriyar, would you like to just say a few words and then we will kick? Shahriyar, would you like to say something?
जी सर, आप बताएं। सॉरी, मैं आई डेंट हियर योर क्वेश्चन।
My question is that while preparing for
हम्म।
exam, what do you think? I try to speak in English because there are some people who are from other countries, so try to speak in English. Okay. So, like neuroanesthesia, what do you think? What are the things which are important for anesthetist, and what do you think? How should you approach uh, learning for neuroanesthesia?
I think first off, the physiology of the neurological diseases and the normal physiology of the nervous system is important to understand, like
Okay, very
how
good.
the autoregulation of the blood autoregulation is done, um, how what influences the intracranial pressure, and all of these things need to be understood. And then what one as an anesthetist must do to assess patients preoperatively, how to manage them intraoperatively, and then how to look after them postoperatively.
Okay, so have you got any idea that what different sort of scenarios are being asked from this topic? Because you know why I'm asking this question, because it is said that you should know your enemy. Okay, so till the time, whenever, like, this is a basic approach to actually learn any topic. Know your enemy. What's your enemy? Okay, like what you should be knowing, or what can be the possible question. Yes, you have told in perfect way that what are the different things which an anesthetist should know. Okay, so if we just dissect a little bit further, that just tell me one thing, that, like, what are the possible scenarios which can be asked?
So normally exam consists of questions regarding the management of head injury patients, um, how to uh, how to approach any patient for neurological surgery, for example, craniotomy, um, and posterior fossa surgeries, any emergency scenarios like venous air embolisms, awake craniotomy, and carotid endarterectomy, patients who undergo um, the uh,
Okay.
who undergo management for seizures, for status epilepticus, and all the other neurological diseases.
Okay, so I have just chalked out some of them. Some of them you have told already. So because usually the question which may be asked is about craniotomy. Okay, and craniotomy, usually it can be any front and temporal, anyone. But usually different things for you will be awake craniotomy. Different thing will be you a little different will be posterior fossa surgery and transnasal. Okay. So these will be a little different from the normal craniotomy. Okay. And usually, if you just think about craniotomy, this will be either for a space occupying lesion, like you can say tumor. A space occupying lesion maybe even blood. Okay, it not necessarily it is like tumor. Okay, it can be even if it is blood vessel related something expanding, it will be also be called as space occupying lesion. Okay, so tumors, or, like, as I mentioned, blood related problems, or it may be for head injury. Okay. So whenever there will be head injury, there will be some bleeding. Okay. So bleeding may be extradural, or what we say epidural, or subdural. Okay. Or it may be intracerebral bleed. Intracerebral, or there is another sub, which is important, is subarachnoid hemorrhage. Okay. Uh, are you understanding, Shahriyar? I hope you are gathering.
Yes.
Okay.
Yes, sir.
So whatever it will be, that the common thing about anything. So let's discuss what are the common thing related to craniotomy which should be knowing, and we will just go a little bit in detail. We will just try to look into that how much we can cover in this session. Okay. So like like whatever is the scenario, whether it is acute will be for trauma, and like if you are planning so something, it will be a tumor. So whenever there is a tumor, you will be looking, we will just discuss few words about tumor. So if it is a brain tumor, the main thing will be of the area where it is. So area will tell the function. Area related to that will be the function. And an important thing will be whether there is some sensory, motor, autonomic, higher mental function. Okay. Because usually these sensory, motor, autonomic, and higher mental function, usually you will be assessing these things. Okay. And okay, so can you see the screen, am I right? Okay. So this is one thing. And then another very important thing is, can you just guess what are other thing you should be knowing? Yes, Shahriyar, with reference to tumor.
Whether patient has any raised signs of raised ICP, any documented deficits.
Yes, that will be, you are right. But actually, we are focusing on the things which you should be, or focusing about the tumor nature. Okay, so actually, whether it will be secreting or non-secreting. Okay,
Right.
because a number of tumors in the brain are secreting tumors, like for example, pituitary tumors. But there are some other tumors which can also be either secreting or non-secreting, because there are certain hormones which are secreted in pituitary. Okay, so secreting tumors like, for example, acromegaly. Okay, prolactinoma. Okay, so just look into it. If it is a pituitary tumor, you should be thinking whether it is a secreting tumor, non-secreting tumor. Okay, and of course, as you were saying, whatever, if it will have any pressure effect, so pressure effect will be in the form of ICP. Okay, midline shift, and any neurological problem related to sensory system, motor system, autonomic system, or higher mental function. So usually, your assessment will be revolving around like what is the size of the tumor, which area it is, how big it is there any vessels around, okay, and is it causing any neurological symptoms, is it a secreting tumor or a non-secreting tumor. Okay, usually brain tumors are benign, usually. Okay, but like you always have to think
Yeah.
that whenever there is a word cancer, it may be a malignant. And another thing, another last point is that maybe Shariar, you must be thinking that maybe they are metastasis. They are not the primary brain tumor. Okay, and
Yeah.
it is metastasis from any other. So you should be knowing whether this brain tumor is a primary brain tumor, or is it is metastatized. Okay, because your approach. Remember one thing: anesthetist has to work like an intelligence agent. Okay, he should be knowing everything. Okay, so that is how I'm sorry, that is how we need to approach our assessment. Metabolic effect, yes, it is related to secreting tumors, as I told you. Okay, so this is how you should be approaching. This is one point I just wanted to tell. And then of course, any specific site, yes, what I was striking another thing, that whenever we are discussing about ICP, there is a concept of Monroe-Kelly doctrine. Okay, anyone knows about it? What is Monroe-Kelly doctrine?
It is a concept stating that brain skull is a closed space and it does not expand. The only way it compensates for any increase in pressure is by um, um, decreasing either removing CSF from the vault or displacing the blood volume. So the contents of the brain skull are going to be constant, and
Yes, like
it
as
has
I
very
mentioned here,
limited room
that
to,
yes,
yeah.
as there is a brain tissue, there is blood and there is CSF. So whatever we are doing, so why it is important to understand that if you are want to, like intraoperatively, someone asked to control the ICP. So either we have to shrink the brain tissue as we give with mannitol, and we have to decrease the blood volume. We give do hypercapnia, okay, sorry, hyperventilation to decrease CO2 so that brain blood volume is decreased because CO2 is the direct determinant of the cerebral blood flow. It is directly correlated to it. So I hope you understand. That's why it's very important to understand the concept of this Monroe-Kelly doctrine. Okay, because there are other certain points you should be know what are the IC waveforms, what are the pathological waveforms. We will try to cover, but I am afraid that I because the way I wanted to give you an overview, you can read about it. What are the various ICP waveforms and what are different pathological waveforms? There are Lundborg waves. You should be knowing about it. I will try to show you, but you can learn about it. And then what are the signs and symptoms of ICP rays, like Cushing's triad, okay? And you should be knowing about it. Of course, people will say intraoperatively, they will say abnormal ventilation. So abnormal breathing will not be there intraoperatively. So it will be bradycardia with the hypertension. Or maybe sometime there may be arrhythmias can also come. Intraoperatively, the how you will be gathering it is that way. Okay. Okay, so we will just try to move on. So, from where we started, that craniotomy. So, craniotomy, these are the things usually you should be you should be understanding how to approach with it. Okay, so let's have some more points about the control of ICP. So, one way is with the control of CO2, other is O2. The third factor is viscosity. Okay, temperature. Okay, CO2, as I told you that it is directly proportional. O2, like there is a graph that if up to 60, it will remain and 60 millimeter of mercury, or if it is going beyond 60, hypoxia beyond 60 millimeter of mercury, certainly it will increase. So it is like the graph is like that. Viscosity, the blood should not be too viscous because as we know the flow dynamics, if there is increase in viscosity, there is decrease in flow. This Hagen-Poiseuille, if I'm not wrong. Okay. And temperature, if the temperature is increased, cerebral metabolic rate is increased. So that is the relationship between the temperature. So how different ways you may be asked if you are thinking about a head injury. Okay, so the main purpose is the primary brain injury has already been done, so you have to avoid the secondary brain injury. Okay, so when we are trying to control the ICP, the main focus is that we have to avoid the secondary brain injury. This is one point. Okay, and so whatever factors, if whatever factors are increasing the ICP, you have to avoid. And how we can avoid the secondary brain injury? The challenges will be that maybe we have to have the airway control in a nice way. We have to may avoid this. We have to do this mills. Okay, we might need to electively ventilate. Okay, and if there is any expanding hematoma, so if there are two different options, either it is EVD, burr hole. Okay, or definitive like decompressive craniotomy sometime also. So these are different option we might be doing. Okay. So another here will be to identify the problem. So CT scan. So CT scan immediately patient need to be taken. So now like what scenarios they can ask you, like with reference to head injury, they may be asking you a scenario, a patient has a head injury and now is in emergency, is very aggressive. So you have to manage the airway and you have to transfer the patient to CT scan. So they would be asking you, or the challenges in this scenario will be that your approach should be airway breathing circulation. At the same time, you should be thinking about ATLS approach. Okay. ATLS approach, as I mentioned to you, that airway control with Mills and minimum, because you have to consider neck injury unless it is ruled out by nexus criteria or Canadian C-spine rule. Okay, so neck injury will be there. ATLS algorithm will be there. And why it is difficult scenario for you to answer, because you don't have to go in details. You will say that our approach, because if you tell some words and they understand that you will pass, and if they want to ask something in detail they can ask you. But if you go in too much details of ATLS to start with, maybe their scenario is only focusing on neuro, and you are just wasting their time by speaking up too much about ATLS. So you can just speak out that our approach will be airway breathing circulation, care of cervical spine, and careful airway management, and all the approach we need for ATLS. If they want to ask something in detail, they can ask you. Okay, so this is important thing. And that time what will can be the problem, maybe if you are considering full stomach, so maybe there are problem related to aspiration, difficult airway as we all discussed. Okay, difficult airway. And another important thing here, you will be considering about fits. Okay, because whenever there is head injury, there are chances of fits. So you have to control the, or to prevent the factors which can lead to precipitation of fits. Okay, because in this scenario these things can occur. So they will be, and then from CT scan what will happen, so another and is a patient transfer. So if maybe they can ask you a question about the principles and about the challenges which you need to know about the patient transfer. Actually, this is a separate topic, but you should be knowing that what you should be needing, the double if it is the transfer, maybe from emergency to CT scan room, or maybe they can expand their scenario that now maybe this patient is to be transferred from the primary care to a specialized neurosurgical unit. Okay, so these are the things which you should be thinking. That patient transfer will be a consideration, managing the airway, controlling of the fits, risk of aspiration, careful airway management. Okay, and a part of this, as we discussed, that ATLS, and then from there maybe they will decide whether they need some intervention in the form of burr hole or decompressive craniotomy or anything like that. Okay, so this is journal approach. Whenever they will be asking you a scenario for for head injury, so this will be the approach. And now you should be knowing that there is only 5 minutes, and in 5 minutes they will be asking you so many questions. So their approach may be in either side. So if you when you are starting your speech, sorry, when you are answering starting your answer, if you cover these basic points, you will pass, because otherwise you will be stuck. Okay, so any question up till now? So up till now, what we have discussed, that what are the various scenarios we should be knowing about neuroanesthesia, and I have just told you few points about craniotomy, and we have just discussed few major points about how to handle a patient with head injury. Okay, and how to manage the airway, Mills, and actually the details of airway, some of the points that you will be using the glidoscope. Okay, so they will be asking you which medications you will be using. So a number of things will be according to the scenario. According to the scenario, they are telling you, because maybe if the tricky scenario will be full stomach. Okay, if you are using rapid sequence induction, there will be problem challenge in the airway management, because you cannot manipulate the neck a lot. So this will be one problem. Then you have to avoid the factors which are causing raised ICP. So you need a way, the balance between, and then the thing which can make the scenario even difficult will be hemodynamic instability. Okay. So usually in hemodynamic instability, you say that we are using ketamine. But here, if you are using a high dose of ketamine, this is also causing high risk ICP. So like these are the challenges. So if they are asking you this question, if you speak out this thing, that in this scenario of airway management, these are the challenges which I have. Okay, so whatever agent I will choose will be according to the patient, according to the patient vitals, according to the situation, and the priority is to maintain the airway, and you can nullify the increase in ICP by giving some medications. Okay, this will be a smart answer for you to have. So, but you should be knowing that these are the things, challenges which you should be facing in this scenario. Okay. Okay, so let's move forward. So, similar to the concept of the secondary brain injury, intraoperatively, what they can ask you about craniotomy, the same question will be about the patient has tight brain. Okay, so how will you manage tight brain? So you will just your approach again will be airway, breathing, circulation. You will make sure your anesthesia is adequate, your analgesia is adequate, and then you will immediately, it will have effect is hyperventilation. Okay, so you will increase both tidal volume and respiratory rate to increase the ventilation, so it will wash out CO2, but your target is around 33 to 35. And transiently, if they are asking, maybe for few minutes, you can decrease it further. In the time you are able to give some other medication which are covering it. So other options will be, what are will be the other options? Can anyone tell? Anyone wants to tell? What will be the other options you can add? Other option
In
which you
order
can.
to
So
in order
yes,
to maintain the ICP,
yes.
so
Brain dehydrating measures like furosemide, mannitol, um,
Okay,
steroids.
okay. Steroids in steroids is specific
No,
for brain
no,
tumors.
no, not steroid. No, not. For what is the question, Manish? Sorry.
That you surgeon is saying tight brain.
Okay, not steroids. This only brain dehydrating measures
Yes.
like mannitol or furosemide.
Furosemide. Okay, Zunera, anything you can add?
so we can start with the hypertonic saline, like line wise. He's right about mannitol. He's right about furosemide. We can
Okay.
also put in barbiturate coma.
Barbiturate coma intraoperatively, it's not a good thing to say.
Not a good. As I also have a question about ketamine. You were saying like we can, like you were saying about ketamine that like we can use it or not?
Ketamine is
Because
not a good choice if you are using in slightly higher dose. You low dose is something else. But you will avoid ketamine. Okay.
like I have been reading in the new evidence, like they are saying ketamine has been
You
back
are.
into the practice as it's
Yes,
not increasing
Junera.
the
So
ICP.
for that, I will ask you to speak out in a diplomatic way, okay?
Uh-huh.
Because
Okay.
maybe the person who is asking the question, maybe he is not aware of this newer. If you ask me, I would use it.
Like
But
in case of when we have to save the CMRO2, then we should go more with the CMRO2. Then ICP is not that much important in that
yes,
sense. No?
no, you are right. I can understand what you are trying to say, but I will tell you that in exam, there are something which you can say that you can use it safely without any fear, and some things which are controversial. Like I
I
will
see.
give example that nitrous oxide. People are there are two kabila in the world. Some love nitrous oxide. I am that in that kabila, and there are some people who don't use nitrous oxide at all. And unfortunately, either of the kabila think that they are other is wrong. Okay, so similarly, ketamine. You can tell that ketamine was traditionally always. So if you want to use ketamine, you should be using cautiously because there are some studies supporting it. So, but it is not widely used. Okay. So
I see.
unless until it is mandatory to use, it's better to avoid. Okay.
Like
So
we titrate it according to the situation, right?
titrate according to the scenario. And again, Zunera. Even if you are appearing like in an international exam, you can tell about the evidence if you are sure about it. But again, remember one thing, that some things which are not in textbooks, okay? So you can again and again you can say in that way that recently there are a lot of randomized RCTs, and a lot of evidence is coming towards support of using ketamine. So you can use in
So
that
we
way.
keep this paragraph in the end of the
Yes,
discussion.
yes. Rather than,
I
because
see.
some people can be offended if you straight away
I see.
speak out. Okay. Viva is
Mm-hmm.
just like a diplomatic way of speaking out. Because whatever you say, you should be very confident, and it's always better to be like a politician. Speak
Mm-hmm.
out in a way that you say and you don't say, and if or you don't say and you say. You speak out in that way. And because the
I see.
advantage will be you can change the party anytime. If you speak out, yes, we can use ketamine, or I will use ketamine, maybe some examiners can catch you. And if you say that I will not use it, some examiners can catch you. So if you want to be in between, you can say use cautiously, as you say, titrated and things like that. Okay. Yes, actually, I
I
wanted
see.
to listen what Zafar Ali has written in the message. That other things you should be thinking, that whether your endotracheal tube is tied very tightly, whether the head you can elevate the head side a little bit, okay? And then when you have make sure that you have your analgesia is good, your anesthesia is good, your everything is in your oxygen level is good, your CO2 level is good, then you will go towards the medications like mannitol, furosemide, okay? So these are the things which you will be considering. Another very important thing is that actually this to be done all the time, but you should mention here that you will do ABGs, and then you will compare the PaCO2 and tidal CO2. Okay. So you can accurately measure the status of CO2, because usually, maybe in any other case, if CO2 transiently increase a little bit, it's not a problem. But here you need to be very accurate. So in one or two sampling of ABGs, you will come to know how much is the difference in PaCO2 and end-tidal CO2 in that patient. So you can accurately monitor the PaCO2, because actually you are not supposed to monitor end-tidal CO2. You have to monitor the PaCO2. Okay. And you cannot do PaCO2 every second. So you have to monitor through end-tidal CO2. So you do whenever they are sampling. And actually, this is a habit. We should make this habit all the time. It's always helpful. So whenever they are sampling, you look at the end-tidal CO2, the number, and when the result come, you compare it, and you can titrate accordingly. So this is another important thing. So tight brain we have discussed. Then, with reference to craniotomy, there are certain other points specific, like awake craniotomy is a separate topic. Okay. Transnasal surgery, as I mentioned before, that whenever they are using this transnasal surgery, so it's like an ENT surgery to start with. So all the concerned shared airway and throat pack and hypotensive anesthesia and these things you should be knowing. And then post-operatively, with reference to transsphenoidal surgery, is CSF rhinorrhea. Okay, so CSF rhinorrhea is expected. It can occur. So actually, when they are closing, they are using different techniques to minimize the chances of this CSF rhinorrhea. Okay, so you should be thinking about it. Awake craniotomy, actually, in awake craniotomy, the purpose, there is a specific indications for doing awake craniotomy, and they are using scalp block to anesthetize the area, and then they are doing the neuromonitoring, and then they are actually just trying. There are different techniques, that whether they are doing sleep, awake sleep, or awake all the way, or awake sleep. There are different modalities for it. Okay. Maybe they are using conscious sedation, like with the Presidex, dexmedetomidine, in which the verbal communication is there. Maybe they want asked to give some commands of moving the limb, or they just. So the awake craniotomy is a little different topic, but at any point of time, patient can become claustrophobic, patient conscious level can be deteriorated, and always you have to be ready to maintain the to converting into to general anesthesia. Rest of the things will be the same. Okay. So now we will go a little further in detail about like because whenever we are handling this scenario, some things are common. So as I mentioned, tight brain, as I mentioned, and then we will just discuss something about neuro monitoring. And there are certain things which in not available in all the setups, but there is a concept of navigation. Okay, that actually navigation as a like GPS. So in navigation, they are just identifying how deep, in which angle they have to approach. So navigation they do. Okay, just a second. So navigation is something which should be knowing about. They can ask you on neuromonitoring. In neuromonitoring, actually, there is a specific department. There is a specific technician who is doing this neuro monitoring, and there are certain challenges. Like whenever you have a craniotomy, you will be asking the surgeon, Are you doing neuro monitoring or no?" So if they are saying neurophysiology monitoring, so now you have to give TIVA. So all the viva can be revolving around total intravenous anesthesia and the concept of this TCI. So there are specific pumps in which you are giving target control infusion. So again, this is a separate topic, but I will just try to give you a bird eye view. Whenever you are using TIVA, you have to be careful that TIVA line should be accessible to you. It's better to attach TIVA in the lower limb. Like it's better to take a line in the foot, so that it is it is approaching, because rest of the hands will be tugged, and even if you attach to CVP, sometime it can create problem. So it's always better to have TIVA line there. This is one thing. Make sure there is no interruption in TIVA, because there is no inhalational agent you are giving. So it's a problem. Some people will say you can give less than 1.5 Mac. Some people will allow, some neurophysiologists will not allow. So you cannot give nitrous oxide, you cannot give inhalational agents, you cannot give muscle relaxant. You have to continue in TIVA. So there will be option of propofol. Okay, there will be option of fentanyl. If it is available, remifentanil is a very good choice. Okay, and this Presidex, this dexmedetomidine. So you are using in various form. They can ask you certain questions about it. Remember one thing, that two medications are in microgram per kg per hour. Fentanyl dose is in microgram per kg per hour. Okay, same is true for Presidex. Okay, and remifentanil and propofol, its dose is around 25 to 200 microgram per kg per minute for propofol. And similarly, remifentanil actually, with reference to remifentanil, remember one very important point. Remifentanil can cause hyperalgesia. So, so whenever you are using remifentanil, when the surgery is finished, you have to compensate. You have to replace it with both morphine or fentanyl. Why I'm using long acting and short acting? Because I have faced myself that morphine takes some time for its effect, and if you don't give anything like remifentanil, you stop. Because another concept you should be knowing about this thing is context sensitive half life. Okay, context sensitive half life, and it is related to the duration of the infusion, and the time in which the blood levels, the clinical effects is going. So context sensitive half life for remifentanil is very short. So if you stop it, maybe in within 3 to 5 minutes, the effect is gone, and suddenly patient will become hypertensive if you have not replaced it with proper. So it's better to give fentanyl. So fentanyl effect will come earlier, and then you can continue with morphine. In the setups where fentanyl or morphine is not available, or remifentanil is not available, things are totally different. But if you have the availability of these hi-fi gadgets, it's always better to understand. There are certain other options of sulfentanyl and alfentanyl as well, but the concept is that you have to replace it with other analgesia before stopping it. So this is something, some few words about TIVA. TCI is a certain medication which has the models and the concept in which you are entering the demographic data, height, age, sex, and then actually they are calculating according to the data which is entered in that machine. And the concept is that that whenever there is you are increasing or decreasing the rate, immediately it is like we are targeting a blood level. So whenever we are increasing the blood level, automatically it will give a bolus, and it will adjust a continuous infusion rate according to the three compartment model. I'm just giving you the buzzwords. You can read details about it, because unfortunately I don't have time to tell all the details. Rather, I'm a little off topic, because this was not the exact. Because of course there are so many things which are related, and so many things I want to tell you. But so TIVA TCI is with this reference to neurophysiology, and then because they are doing motor evoked potentials, so you can give an initial dose of muscle relaxant, and after that, they will put pins all over the different various places to identify various nerves. They will put something in the mouth. They will, so you have to put the white block. Okay, so you have to, they will put it in the different various nerves, in the lower limb tibial nerve and all the nerves. So they will put needles all over the body. Okay, and to monitor the these motor work potentials, and you have to know about the sensory evoke potentials. So motor work potentials, sensory evoke potentials,
अस्सलाम
and
वालेकुम।
actually they are
तो
also
तबीयत ठीक हुई तेरी? शुक्र है, शुक्र।
sensory evoke potential, brain stem, auditory evoke potentials. Okay, and visual evoke potentials. So they are on monitoring these things. So you have to avoid the medications which are changing two things. You have to know this word amplitude and latency. Okay. So there is concept of latency and there is a concept of amplitude. Amplitude is that how bigger is response is coming. And latency is that when you are giving any stimulus, after how much delay the effect is coming. So latency is the latent period is the one in which the effect is not coming. So latency, so these inhalational agents, they all affect the both only, not only latency and amplitude. So amplitude is the response, the how big is the response, and latency is that in how much delay the response is coming. So whenever they are asking you about these things, you should be knowing about these few points you should be knowing. Okay, so these are these are some important point about craniotomy. So there is always a debate if you are using CO versus ISO. And I'm not sure about that, because when I used to work back in Pakistan, it was isoflurane. Sevoflurane was not available in some of the setups, and now recently they are using sevoflurane. Data, there is conflicting data. Some data is saying sevoflurane, some is isoflurane. So there are certain things you should be because in oral, yes, PEEP. Yes. So yes, you were right. You were right with reference to ICP. It was the right point. I just have a look. I had a look right now. So these are the things which should be knowing, and you should have good multimodal analgesia, avoidance of all the factors which is affecting the ICP. And another thing, now few things, suddenly bleeding can occur. This is one point. And actually, another thing is that because if when they are doing under microscope, or when they are doing even this openly, because there is a lot of oozing which is coming. So sometimes it's very difficult to estimate the blood loss. So you have to be very carefully looking into the surgical field. Okay, because the blood bleeding will be occurring slowly. So you have to be very careful. So bleeding can occur. Then another important thing is air embolism. Okay. So venous air embolism can occur in any of craniotomy, especially in posterior fossa surgery. And you have to be careful about it. Like you usually what we do, that we attach a syringe with saline, a big 50 cc syringe to the distal port of the CVP. Distal port, remember, this is very important, because if you are aspirating, if you are attached to the proximal or in middle port, you will aspirate all other things as well. So it is always to be attached to the distal port of the CVP in the triple lumen CVP. So this is one thing. And then you will do the head side down the surgeons will irrigate the saline, they will use the bone wax. Okay, so the same question they can ask you, what is the approach? Suddenly, what will happen? The end tidal CO2 will be gone suddenly. So until unless prove otherwise, you will be doing your approach will be airway breathing circulation. Stop the surgeon, inform the surgeon, and then, as I mentioned to you, and then according to the scenario, if any arrhythmias occur or cardiac arrest occur, you will be doing according to the ACLS algorithm. If any arrhythmia occur, you will use the arrhythmia accordingly, and then vasopressor or inotropes if required. So through this one, and if you have a facility, of course, this transesophageal echo is a sensitive indicator to identify even very small amount. I don't remember exactly. I think 0.5 ml, if I'm not wrong, because usually
Yes,
these
sir, it's 0.5.
0.5. Okay, so this is the most sensitive, and then end tidal nitrogen is increased and end tidal CO2 is decreased. So that's how it happens, because air will enter. Actually, air embolism technically can occur in any surgery occurring above the level of heart. So even in the carotid surgery, even in the thyroid surgery, it can occur. Usually it does not happen, but it can occur. So this is a question which they can ask you about air embolism. So we will just expand few points about this beach chair position. Actually, the same concerns will be there, but here there will be certain other points which there will be more chances of air embolism. Zunera, can you tell some points about posterior fossa surgery in beach chair position?
Sir, about this air embolism, yeah, this is one of the most common cause.
No, other points about posterior fossa.
Like the
Any other
anatomy.
complication? Any other surgery complications which can occur in posterior fossa?
Yeah, we have that the venous congestion, the edema of the tongue, macroglossia.
Macroglossia, vital centers are here.
Sorry?
Vital centers, there are more chances of post-operative ventilation.
Yeah, and if we are doing that park chair position, we also have this, no, the macroglossia things.
Yes.
The edema, the optic nerve ischemia.
Okay.
Others, like if the abdomen is not well fixed and is not hanging, we can have the abdominal compartment syndrome.
Posterior fossa, it depends on which surgery we are doing. Position in
Yeah, and the
it,
position, exactly. We have
not
many positions.
yes. So we are talking about beach chair position, or you are talking about prone position?
I was talking about part wheel.
Actually, in posterior fossa surgery, this macroglossia and everything will be occurring if you are doing posterior in prone position, isn't that?
The park wheel position.
How macroglossia will occur in this position?
Like if we are, it's proning, but it's opposite to the park wheel position. Like the face will be down on the headrest.
Yes.
It's a sitting
So it's
position.
prone. I'm sorry, maybe I'm just myself is confused
You are
about.
right, actually. You are actually right. It's kind of proning, but it's sitting proning.
Okay. Okay, I understand. And actually, this is considered as prone position because there is a beach chair position in which they are doing some craniotomies. So it's a little bit different. Okay. So, anyways, these complications can occur. Spinal cord ischemia due to edema in sitting position. How it will occur, Zafar? Can you speak out? Spinal cord ischemia due to edema in sitting position. Actually, if you are doing any surgery in hypotensive anesthesia, then there are chances of spinal cord ischemia. Okay. So, Zunera, I think I myself is a little bit confused about the positioning. If you can just read the text and just reconfirm. Okay.
About the sitting position that I have been talking?
Yes.
That one?
Yes. Yes, if you
Okay,
can just
okay,
review and just you can just tell in few minutes. So, anyways,
okay.
so these are some important the points about craniotomy, head injury. Actually, neuromonitoring will it will also involve this 12 at what is called as full channel EEG. So they are monitoring the EEG waveforms. So they can ask you, especially to Zunera, in your exam, they can ask you about EEG as well. So you should be knowing about some some more about it. And then we have the simple numerical number of bits or entropy, okay, in which we are monitoring the cerebral they are telling this is called as actually processed EEG, in which they are just telling the cerebral activity in a number. So as number is decreasing, so usually the target anesthesia is around 40 to 60 in BIS. So this is another important point. Just a second. What else is left? There is recently, I don't have much experience about it. There is one O3 and SED line. Okay. So you can read about it. There is a O3 which is attached to a new machine which is Massimo. I have not read much details about it, but I'm just telling you a name so you can read about O3 monitoring and SED line. Okay. So another thing you can do is you can do EBG and VBG. Okay, so it is also indirectly telling you about cerebral oxygenation. These are something related to it, and okay, so we have covered some important points related to neuroanesthesia. Let me think. Let me take you back to from where we started. That whenever we are evaluating a patient, so there is one sensory system you have to evaluate, motor system, okay, and higher mental functions, okay. So usually, we have to do the sensory examination, the motor examination, the higher mental functions, the conscious level. But you should be like if you are evaluating a neurosurgical patient preoperatively. So there is one is AVPU, okay, or GCS. Usually we use this awake, verbal, pain, or unconscious. So this is one thing. And then, objectively, we do CT scan. Okay. Uh, if you are talking about that carotid, so the carotid Doppler or the this CT angio, CT angio. Because another scenario now coming back to from where we started, that what are different scenarios? There will be another scenario of stroke. Okay, they can ask about stroke code or stroke team. Okay, so this is the same algorithm you have to follow. Cincinnati score, I don't remember exactly, but you should be knowing about this stroke code, how to identify a patient with stroke, and then they can take you the next part of the scenario maybe in the interventional radiology. So anesthesia concerns in interventional radiology. So this is a scenario which if people have not worked in that setup, there will be a problem. So interventional radiology, actually, they are doing a lot of procedures. They are doing cerebral angiography, they are doing clipping, they are doing like so many procedures, various sort of procedures they are doing. So the main points about interventional radiology is that it is out of OR or ambulatory anesthesia. Okay. What you say, NORA, non-operative room anesthesia concerns. Okay, limited patient access, and even the table there is not a proper table for intubation. So you can have problem related to it. And a number of times they are doing in conscious sedation. So suddenly this patient can have reperfusion injury. These patient can have fits. This patient uh, can have decrease in conscious level while performing the procedure. So you should be knowing the challenges which you can have. So the scenario will be revolving around a patient coming with the difficulty in speech or weakness. So you should read about it. The stroke code. Okay, I am not very good in this topic, so I'm just telling you an idea. Yeah, but you should prepare this topic because they can ask you this topic with the stroke leading to interventional radiology. So interventional radiology these patients, all the cerebral concerns will be the same, believe me. Now, the things which we have covered about the cerebral perfusion pressure and cerebral blood flow and ICP, how to control it. But here you will be telling about Nora, you will be telling about any anticipated problems. Okay. So any question or anything you want to add about it? Yes, Zunera, what is this? What is the name of this position you have sent the
We
pic-
can say it like lateral oblique. It's said like the park position.
park?
Sitting park, yeah.
What is the full name?
Park bench.
Park bench. Okay. Now, actually, in our hospital, they are doing in prone with head hanging. So that's a little different. I have not done any surgery in this position.
Mm-hmm.
So,
I
so
see.
this is different. This is different. Yes,
Okay.
you are absolutely right. This is the complication which you were telling were in this position. Okay.
Okay.
So let's have a look here on just a second. So neuroanesthesia is a topic which I don't think so. Any exam will be finished without asking about neuroanesthesia. Okay, so let's have a look. So cerebral physiology. So as I told you, they can ask you about what are the factors which affect the cerebral blood flow, cerebral circulation. Yes, in some basic sciences exam, they can even ask you about circle of Willis. Okay, so they can ask you about circle of Willis, and they can ask you even about the graphs. I was telling you about few of the points with reference to this viscosity, as I mentioned to you. Okay, and then I think it will be here. This is cerebral metabolism and cerebral blood flow graph. This is with reference to CO2. Okay, and because the in the other range, it is a little different relationship because it will have compensation, and but usually it gradually increase with increase in CO2. So this was about oxygen, that if it is maintained, it is maintained. If it is going less than 60, suddenly it will increase the cerebral blood flow, as I was telling you. Okay. So if it is a minor hypoxia, and there will be not much effect. But if suddenly, you see here it is maintained, as is go below around 60, suddenly it will increase. So it is ml per 100 gram per minute. Okay. So this is another important concept with reference to autoregulation in the blood pressure, that between 60 to 160, it will remain constant. But hypertensive patients, their graph will be shifted towards right. So their mean may be coming not 60, maybe 80, for example. So in that patient, you have to maintain accordingly. And cerebral perfusion pressure is mean arterial pressure minus CVP. In some books, it is written CVP plus ICP. In some books, it is written CVP or ICP, whichever is greater. So usually, because intraoperatively you can monitor CVP, not all the time you can monitor the ICP. So you will just anticipate. Okay, so as I was mentioning about temperature, so there is seven cerebral metabolic requirement, decrease 7% for each 1 degree centigrade fall. These are more of MCQ question, but they can ask you, especially in basic sciences exams. So few articles about cerebral physiology, and then head injury, as I mentioned to you. If some important point, one important point I just missed at that time, we will see here that what are the indications of CT scan, what are the indications of transfer to a higher surgical unit, what is nexus criteria, what is cerebral C spine rule. These are the things which they can ask you about GCS. It looks very easy, but sometimes they can give you a scenario and ask you to calculate GCS. This is more important with reference to OSCE exams or basic sciences exam, but they can ask you. So you should be knowing about it. So these are urgent CT scan. When will you be doing urgent CT scanning in head injury? So these are some points. GCS less than 13 or 15 after 2 hours. And then there is base of skull fracture, or there is a suspected open or depressed skull fracture, post-traumatic seizure, focal neurological deficit, or vomiting. Okay. So this is one of the sign of a raised ICP. Okay. Any history of amnesia or loss of consciousness post-injury in a patient who is coagulopathic. So this is some, so they can just ask you about that. When will you refer the patient to neurosurgical event? Actually, these questions in not valid in all setups. That's why we don't remember. So because usually it's for the places where they have specific neurosurgical units. So even in big hospital, they are referring the patient to neurosurgical. Okay, presence of new surgically significant abnormalities on imaging, GCS less than 8 after initial resuscitation, and confusion lasting more than 4 hours, deterioration in GCS after admission, progressive focal logical signs, seizure without full recovery. You can just have a look. These are cramming stuff, but I'm just telling you what will be the reasons of intubation. They can ask you in this thing. You, if you forget, you can tell the baseline things. And if the conscious level is retreating, or there is hypoxia, hypercarbia, loss of airway reflexes, significant bleeding into the airway, hypoxia, hypercarbia, too much hyperventilation, irregular respiration, GCS less than 8, seizures. So these are questions actually they can ask you. And that how to manage the severe head injury. So this in different books you will find different. In majority of text you will find 33 to 35. Okay, if you go too much low, it will even that will be bad because it will cause vasoconstriction. Okay, so mean arterial pressure, temperature, glucose. I forgot to mention about hyperglycemia, because hyperglycemia will increase the neurological injury. Okay, temperature, and then you monitor the cerebral perfusion pressure. Okay, so these are the things which we have discussed in our this 50 minutes discussion. So mannitol 0.5 to 1 gram, 1.25 gram per kg. Usually, it is 20%. So sometimes it's difficult to calculate. You should be knowing that 1 ml will be 200 milligram. So you will calculate according to the weight, and then you will divide it in the volume. So that much volume you need to give. And mannitol, when they give, initially there is hypervolemia, because what it will be doing, it's a heavy molecule. Okay, so it will bring out fluid from the cells. So it will reduce the cerebral, uh, it will shrink this intracerebral volume. And then if the patient's is already overloaded, or any condition in which patient does not have very good systolic function, it can create problem, and it can lead to pulmonary edema. Okay, so that you should be knowing what will happen. And sometime, because whenever there is head injury, other than mannitol, there is some problem in ADH, or there is and sometime there is a lot of volume loss, so you have to replace accordingly. So there is a separate topic of disorders of sodium balance after head injury. So you should be considering these things about those things as well. Okay. So mannitol, as you was mentioning, Zanera, so thiopentone can be used to suppress cerebral metabolism. Barbiturate comma, again, these things about such things you should be telling at the end, not at the start. Okay. So head injury, head injury. Okay, so any question you want to ask? Anything? I just try to give you an overview about this topic. So actually, cerebral neurovascular conditions we will try to cover separately, because that will have carotid surgery and subarachnoid hemorrhage. Actually, in subarachnoid hemorrhage, majority of the things are the same. One thing is that because there is blood in the subarachnoid cavity, so there may be a concept of cerebral vasospasm. So initially they used to have a triple H therapy, in which there is hypervolemia, this hypertension, and what was the third H in triple H therapy? Hypervolemia, hypertension, hemodilution.
Dilution,
Okay.
sir, hyperdilution.
hemodilution. So, is this Zishan? So, where are you lost?
Yes, sir.
So, you are just hiding. I just listened to your voice just now.
Yes.
So, recently they changed that it is not triple H. They are not doing hypervolemia. They are doing euvolemia. They don't. They want to avoid hypervolemia. So, I think I will just stop here, and you can have a look here because I have given you an overview. And now when you will study, it will become very easy. So we discussed about neuromonitoring, we discussed about head injury, we discussed about basic concept of neuro anesthesia. Okay. So thank you very much, all of you. Uh, you will find here articles about this brain tumor, awake craniotomy, posterior fossa. You see here. This was the position sitting. Zunera, are you here or you are not? You are still here? Yes. So
Yes,
this
I
is
am
the
here.
so this was the picture you were showing. Am I right?
Yes.
Yes. So pneumoencephalus is also a complication. Is recognized completion of surgery in the sitting position. During surgery, various techniques may be used to reduce the volume of brain, which encourages air to enter the intracranial space. Quadriplegia, because neurological injury can occur, post-operative problems related to it is actually maybe you need to ventilate the patient, but in with the evidence of very good techniques of neurosurgery, usually in majority of time we extubate the patient. Majority of time. Okay, because when we don't have the facility of this neuromonitoring and this navigation, the results of neurosurgery were not as good as they are today. The surgery becomes quicker, the surgical time become decreased. Yes, the anesthesia time increased significantly, but actually the actual surgery time decreases because because of the accuracy which they get from this uh, 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 identifying the place from where they have to remove the uh, this one tumor. Okay, so I will share these. You all have got this link, so you can have. They can ask you about the awake craniotomy. As I mentioned to you, these are certain indication, contraindications, as advantages. Usually, it's a challenging thing. So the concept of scalp block, and they can ask you about these crazy nerves. It's very difficult to remember the names of these nerves. Lucky, Luckily, I don't have to appear in any exam now. So you should be knowing about these things. Uh, you should know about this nexus criteria. You should be knowing about cerebral C-spine, uh, cerebral oximetry. Okay, so I will stop here. Thanks a lot, all of you. So tomorrow uh, we will have another session, inshallah, but it will be a little earlier at 6 p.m. Pakistan time. Okay, so thank you very much. Bye bye.